Hi, my name is Ellie Murray, and I'm an assistant professor in the Department of Epidemiology at Boston University School of Public Health. So today I'm going to talk to you about using mathematical models to turn assumptions into knowledge. And the focus of this talk really is going to be about what things do we need to assume, what things do we need to believe are true in order to understand and make decisions from mathematical models. So the slides are okay, right? Okay, so the first thing we want to think about is what the target of our question is. Why are we using mathematical models in the first place? And usually the purpose of them is that we want to know one or both of these two things. First, what will the world look like at some time in the future? And second, how would that world be slightly different if we change something? And so the best way to answer that question is to have a time machine. If we had a time machine, we could take some action now, or even not take an action now, go into the future, see what happens, get in our time machine, come back, and then do something else, see how that differs, and then come back and take the right decision that gives us the best outcome. Obviously, we don't have a time machine yet. So if we don't have a time machine, for most of the types of questions that we want to answer, the next sort of best way of getting an answer to these questions is to do an experiment or a randomized trial. And in this setting, we would basically then assign people randomly to have the different exposures that we're interested in. Maybe one exposure would just be let nature take its course, and one exposure would be give a treatment, and then we see what happens to those individuals over time, and we use that to make decisions about future individuals. But there are lots of times when we can't intervene. So, for example, if we have a harmful exposure, we certainly are very reticent to intervene by giving people SARS-CoV-2. But also, a lot of times we have time constraints, so we need to make a decision now and not 6 months or a year from now. We may have cost constraints. Randomized trials can be quite expensive, or we may be interested in a population that's hard to access. So these are some of the reasons why we may not be able to do a randomized trial or other type of experiment. And in this case, instead of just relying only on experiment or randomized trial, we're going to need to use our subject matter knowledge to ask good questions and get good answers. And so the sort of next best way to do that, if we don't have a randomized trial, we would like to emulate what would have happened if we could have done one. And so typically we do this with observational data. We start by finding some people who have the exposures that we're interested in, and we separate them into groups and see what happens to them. The problem with observational data is that it's hard to analyze. So some of the really important key questions: who should we include in our data set? When did baseline start? This is particularly difficult if we're interested in some kind of exposure like never have the treatment. It's not very easy to tell when never starts. And then why did exposure happen or not? And this is kind of the issue of confounding. So we have a solution in the case of observational studies, which is the target trial framework. And this says that we should explicitly define and mimic features of the trial that we would have liked to have done. And this way, we get an answer to that question about randomization or experiment, but using observational data. But even observational data isn't always available. So we may not have enough data. So, for example, in the current COVID pandemic, we initially really didn't have a lot of data. And so it was really hard to ask some of these questions observationally. We may be interested in knowing about some existing exposure or treatment in a new population. We may be interested in knowing about a novel indication for an existing treatment, or even a hypothetical exposure or treatment. So how good would a medication have to be to reduce the likelihood of death by a certain amount? So when we have these types of situations where we can't even rely on observational data, what else can we do? Well, we're still going to use the target trial framework, but instead we're going to emulate with simulation modeling. Simulation-based approaches give us faster decisions than observational studies or randomized trials, and they require less data. So those are the two big pluses of them. But they're really a tool for combining our subject matter knowledge, the available data we do have, and our best guesses about the way the world might be working into a quantitative prediction. So anytime that we're not using data into our simulation modeling, we're replacing that data with some assumptions or subject matter knowledge. So what kinds of simulation modeling do we have available to us? The first, we have two types, group level and, group level and unit level. So the group level simulation models are things like compartment models, Markov cohort models, and the SEIR models that you may have seen a lot in the news lately from COVID. Then we also have unit level models. So these models, instead of simulating groups, simulate individuals, and they could be called individual level simulation models, agent-based models, or microsimulations. When we're thinking about group level models, the way that these work is basically by lumping people together by some key characteristic. And so the simplest thing to do is to lump people together who are all susceptible to a disease, then all people who are infected with that disease, and all people who are recovered from that disease. And then we basically just sort of map the flows between those groups of people without worrying about particular individual characteristics of those people. So we think about what is the average rate at which people move from susceptible to infected or from infected to recovered. Because of this, group level models are basically, one of their key assumptions is about speed. So we're thinking about how fast or slow the infection transmits between people, how fast or slow people recover, in terms of how the flow of individuals is moving from one compartment to the next. The other type of assumption we need in group level models are assumptions about structure. And so here we need to think about how we're setting up those groups of individuals. So in an SIR model, we have susceptible, infected, and recovered. Sometimes we don't think that people immediately become infectious, so we might have susceptible, exposed, infectious, and recovered, which is a SEIR model. We also might want to know whether contact happens randomly between people. If it doesn't, we may need to separate our model into extra groups to include, for example, individuals in the community versus individuals in institutional settings like nursing homes. We need to make assumptions about whether the recovered people are immune, or do they need to go back into the susceptible box, or should they go into a sort of special susceptible box that has a different likelihood of being infected. And then we also need to think about other types of flows in and out of our model, like birth or death rates. And these are the all sort of structural assumptions about our group level models. Whenever we're using a group level model, we want to make sure that these assumptions are tested and reported. So if you see a model that's reporting an answer from an SIR or other group level model, you want to make sure that they're telling you about what parameters they're using and what structure they're using, but also if they change their parameters, how much does a model change by? One of the common ways of doing this is to specify a distribution around the parameters and vary the parameters you use from that and see how much that results vary. And so in here, the parameters refer to those speed assumptions. And then lastly, if they make assumptions about structure, which they do make assumptions about structure, if they vary those assumptions, how does that impact the model results? So these are the types of things to think about in group level models. In individual level models, instead of lumping everybody together based on certain types of characteristics, we're allowing our individual units to have sort of virtual lives that evolve based on their own particular characteristics. And so in this example, there are a set of individuals who have some exposure, infection status. They progress over time to become infected, to recover, et cetera. And these rates of infection and recovery can be dependent on particular individual characteristics like age, race, neighborhood, exposure level, and it can also be dependent on things like connections between individuals. So we can build in a network that says, one or two of these people have come in contact and there's an opportunity to transmit infection between them. So individual level models, in addition to assumptions about speed and structure, are making assumptions about risk factors. So we need to think about what types of people are in the population, what determines who comes in contact with whom, what determines who gets sick, what determines how long until someone recovers or dies. So these are all sort of thinking about what are those factors that matter in terms of determining the individual life. So one way to think about individual level models is that they're group level models where the groups have become so diverse that each group is just a single individual. So rather than having one group for hospital, susceptible people in a hospital setting versus susceptible people in a nursing home setting versus susceptible people in the community, you've gotten it down till every susceptible person is susceptible in their own particular way. And so thinking about what those factors are that are important for determining who those people are and how they differ from each other. Another thing about simulation models, individual level simulation models that's nice is that I like to think of them like layer cakes. And so like a cake, we can have a layer on the bottom that specifies the individual life history. And this tells us, whether somebody is at risk for a bad outcome or a good outcome, whether they're more likely to get infected or not. And then we can build on top of that things like environmental exposures. So we can put them into space and say, this individual lives in a more contaminated environment and this individual lives in a less contaminated environment. And we can also build things like contact pattern layers. And this will allow the individuals to come in contact with each other and transmit preferentially between each other based on the types of contacts that they have. And so this can be useful if we have individual level simulation model that looks at a whole population, but we think, people tend to socialize in age groups. And so you're much more likely to socialize with someone in a similar age range to yourself. So these layers are really helpful for getting a better picture of what's happening in the simulated world that we're creating. But the more layers we have, the more assumptions we're building into our model. Each layer that we put onto this individual level simulation model has its own assumptions. The choice of layers is an assumption about what is important. So if we decide not to have an environmental layer, then we're assuming that the environment is not important for determining the outcome or the exposure. We can also think about the ways that information flows between layers and how that has assumptions. And so together, these add additional structural assumptions to our individual level simulation model beyond the ones that we had just in the group level model. But just like with a group level model, the assumptions in the individual level model should be tested and reported. And so we can ask the same types of questions about an individual level simulation model as we asked about a group level model. If the parameters change, how much does the model change? If the parameters are drawn from some distribution, how much variation do we see in the results? And if we change the model structure in some way, how much of an impact does that have on what happens to the individuals in the model? So that's not all. So those are the things that we need to assume or to think about if we're just building a simulation model and we want to compare simulation model under conditions A to simulation model under conditions B. But usually we want to do more than that. We want our simulation model to replicate something in the real world so that we can use it to make decisions about the real world. And in this case, we need to start thinking about how the real world works and what the causal structure of relationships is in the real world and make sure that we build those into our model. So for the next part of the talk, I want to kind of go through what assumptions we need to think about in terms of causal structure and how simulation models are a little bit more difficult than observational studies or randomized trials from that perspective. So to do this, I'm going to consider the simplest individual level model. So one with individuals in a single layer that don't interact with each other, and they have no neighborhood or environment to worry about, and they're not actually transmitting information. They're just each living their life as it comes in a sort of chronic disease setting. And this is just because this is the simplest thing to think about from a causal inference perspective. But everything here applies to these more complicated models. So as I said, when we're thinking about the simulation models versus observational emulation of target trials or actual target trials, one of the benefits of simulation models is that we have less data requirements. But every time we sort of take away the need for data, we have to replace that with some assumptions. And so we have this kind of trade-off between data and assumptions in the two methods. But for that trade-off, we actually do get an extra benefit in a simulation model, which is that typically simulation models are designed to allow us to make causal inference in many populations. So for example, if you've followed any of the COVID simulation models, you know that most of them will give you a simulation model for both a country level and sub-country levels like states, or for many countries. And so you can sort of choose, oh, I'm interested in this country or that country, and the simulation model will make you make some predictions for that population. In contrast, when we do observational studies, we typically start by restricting our inference to that single population where the data came from, and then thinking sort of as a next step, how do we generalize that to other populations? And so this is a place where the assumption data trade-off is kind of in favor of the simulation models. So I want to talk a little bit about how the steps of building an observational emulation of a target trial and a simulation-based emulation of a target trial using, for example, an agent-based model, how they compare and how they differ. So in an observational emulation, the first thing that we're going to do is choose a population of interest and collect some data. And so this is defining our cohort or defining our target population we want to know about, and we go out and we collect some data with a survey, or we pull some data from electronic medical records. Once we've done that, we use the data to estimate how likely things are to happen to individuals in this data set. So we estimate the distribution of the confounders, we estimate the distribution of exposure, we estimate effect modifiers, et cetera. And so these are all conditional likelihoods or probabilities of various different life events. In a simulation model context, we need to start also by defining the population that we're interested in. And this could be, as with many of the COVID models, the entire world, or it could be something much more specific, like girls with perinatal HIV infection who are born in the United States, which is a model that I've been using. Once we've defined our population of interest, in the simulation model setting, instead of estimating the conditional likelihoods of life events from our data, because we haven't collected any data, we have to instead make assumptions about those conditional likelihoods. And here, assumptions is a little bit of a loose usage of the word. Some of those assumptions will come from data that we have access to and that we can estimate the values of these parameters ourselves. Other assumptions will come from published studies, and some assumptions will come from a sort of expert best guess. But in general, we have to find sources for these various different conditional likelihoods of life events and combine them all together. But once we have that, we can actually do something very similar to get an answer to our target trial using both observational data and simulation modeling. And so the easiest way to make those two the most similar is just, in both cases, we take these conditional likelihoods that we have and we simulate using something like a Monte Carlo simulation to get a sort of virtual cohort of individuals who live life according to our assumptions or our estimates about the conditional likelihoods of life events. From those, we can then start making perturbations to those simulated cohorts. And under various perturbations, we can see what are the different counterfactual outcome distributions that arise when we change exposure in some way that we're predictably understanding how to change. Okay, so an example to make things a little bit more concrete. So we can imagine that we have a patient who's newly diagnosed with HIV, and she has some baseline CD4 cell count, which is a measure of immune function at time 0. So that's the little 0 index there. We have to decide, should she start antiretroviral therapy today, or should she wait and start with some delay, perhaps after her immune function or her CD4 cell count has worsened to some lower value. Antiretroviral therapy and CD4 count are both independent predictors of mortality, and there may be some other independent predictor of mortality, such as hepatitis C, which could also affect her immune function over time. So let's briefly talk about how Monte Carlo simulation works. So the idea is that we pull some random numbers, we use them to generate an individual at baseline, pulling from distributions. So in this case, we randomly generate a woman age 28 who has a CD4 cell count of 350 cells per millimeter cubed. We then are ready to move to the next time point, and some of those characteristics may either be fixed in our simulation or evolve at some deterministic way. So here you can see age increases by 1 month, or 1/12 years. And then other characteristics are going to be probabilistically determined. So we run some more random numbers. We might, for example, pull from the distribution that her CD4 count is likely to decrease by 5 cells per millimeter cubed. Based on that, we would calculate her new CD4 count at 345. We might also pull a probability of death. We could just keep the probability of death as a variable, or if we want, we can then pull from that distribution and determine that she's alive at time 1, at the end of time 1. And then we move to the second time point and we do the whole thing over again. And so this sort of sequential simulation of time points of individuals is what we're really talking about here for Monte Carlo simulation. So let's go back to what our beginning question is. We want to know, should we treat this patient now or should we treat her later? And when we think about our question in terms of causal inference, what we're really asking is, what will the world look like in the future if we do treat her? And what will the world look like in the future if we don't treat her? With respect to some specific aspect of the world, which for this patient is how well she's doing in terms of her disease progression, or possibly how well she's doing in terms of survival at some specific time point. So again, ideally, we would like to have a time machine, but since we don't, we have to make some assumptions. So simulation models can be thought of as a way to emulate what we would have learned if we had conducted an observational or randomized study, which means that we need to make all the assumptions we would have made in those studies when we were using them to make causal inference. So I want to recap what those assumptions are, because I think they're very important and they're often not explicitly discussed even in our observational studies and randomized trials. So first of all, we need to make the assumption of no unmeasured confounding. So this means we have no common causes of our treatment and our outcome that aren't measured and known in our data. So for example, if we look at this schematic from before, we can see that CD4 cell count at time 0 is a predictor or a cause of antiretroviral therapy and a cause of mortality. So we need to make sure that that is measured and controlled for in our data. The second piece we need is no open colliders. So a collider is a common effect of the treatment and the outcome, or a common effect of a cause of the treatment of the outcome. And we need to make sure that those variables are known and not conditioned on in the data or the analysis. So for example, CD4 count at time t is a collider because it's a consequence of antiretroviral therapy and it's a consequence of hepatitis C and mortality. So we need to be careful how we handle the time varying CD4 count after baseline. The next type of assumption we need is something called positivity. And this is the idea that there's a non-zero probability for all types of individuals in our population to receive all of the levels of exposure that we're interested in. So what this means is if there are certain people we would always treat, for example, pregnant women, or never treat, for example, those who are allergic, we should exclude those from our population. We should not be trying to make causal inference about what would happen to them if we gave them the other level of exposure, because we have no real knowledge of what would happen because we never do it. Instead, we want to focus on the types of people who sometimes do and sometimes don't get treated. And then lastly, we need the assumption of consistency, which basically says that our treatment levels are clearly specified. And this is sometimes called a well-defined intervention or a well-defined causal question. And really here, the issue is that we want to be able to know that the question that we answer with our study is one that we can take some action based on, and it's something that we can understand. So does high cholesterol cause heart attacks is not really a great question, because what do we do if we find out the answer to that? Instead, if we ask a question like, will a cholesterol lowering drug reduce the risk of a heart attack, that's a question that we can kind of move forward from the answer, because we can then give people or not that drug. So why are well-defined causal questions important? So the main thing that's important about well-defined causal questions is when exposure can happen through multiple routes. In that case, so in this example, we have maybe exposure can come about through diet, through medication use, through genetics. In that case, when we're estimating the effect of that exposure, really what we're doing is we're estimating the effect of those multiple ways in which exposure can come about, averaged over all of those ways, based on the distribution of those ways in the population. But so this is giving us a weighted average where we don't know the weights and we don't know what we're averaging over. So it's hard to understand. But even worse, if we don't know all the ways exposure can come about and we don't know their frequency, it becomes a lot harder to know what all the possible confounders are. And so now, even that weighted average causal effect is not necessarily going to be validly estimated, because we may have all of these unknown confounders. Okay, so those are things that we need in every kind of study we do: randomized trials, observational studies, and simulation models. But simulation models are actually a little bit harder. And that's because in a randomized trial or an observational study, we need those assumptions I just talked about to hold for the exposure and the outcome only. But in a simulation model, because we're going to make assumptions about all of the parameters for ourselves, taking them from various different sources, we need these assumptions to hold for every single pair of variables that we're simulating in our model. And so this rapidly becomes very complicated. And it leads to a couple special challenges. So for example, one special challenge is the issue of a well-defined mediator. If we're going to answer our question with observational data, we only need a well-defined causal question about treatment. But if we're going to use a simulation model, we also need a well-defined question about the mediator. And usually mediators are things that are particularly hard to ask well-defined questions about. For example, what does it mean for CD4 count to have a certain value when we do and don't change antiretroviral therapy? And this particularly comes in when we're trying to parameterize the mediators. So for example, in our simulation model, we might need a variable that represents that arrow that goes directly from antiretroviral therapy to mortality. And that arrow represents the effect of antiretroviral therapy on mortality when CD4 count is held at some fixed value. But how do we fix it? What does it mean for CD4 count to not change, even when someone is or isn't given antiretroviral therapy? And then also, what value should we choose? Does it matter? Is there a different parameter for that arrow when CD4 count is fixed at 100 versus 200 versus 1,000? Do we potentially have 1,000 different values for that parameter? 10 different values? How do we determine that? So this can make it really difficult to parameterize our simulation model. Another complication of simulation models is that the parameters are typically coming from more than one data source. And in order for that to be a valid thing to do, we need the parameters to be externally valid. And this requires an additional assumption that we don't need for our observational studies or randomized trials until we want to generalize the results to some other setting. So external validity requires that we have no unmeasured outcome causes, or that all of the outcome causes that might be effect modifiers are identically distributed between populations. So this is the question of why is the outcome happening, and does that matter between populations? And so you can see in our schematic for our particular example, hepatitis C is an alternate outcome cause. If we have different populations with different levels of hepatitis C, then we might expect that an observational or randomized trial conducted in one population may be valid for that population but won't generalize. But a simulation model may be completely invalid regardless whenever we mix and match the inputs. So how does this all work? Can we actually use simulation models to get causal inference? So I'm going to show you quickly some results from comparisons of observational emulations using something called the parametric G formula, which is basically what I described with that. Choose a data set, estimate conditional likelihoods, and then do a Monte Carlo simulation approach, and then using an individual level simulation model. So first, we're going to think about two populations that have this structure that we've been talking about, except one population has a low prevalence of hepatitis C and the other has a high prevalence of hepatitis C. And because of that, one population has low mortality and one population has high mortality. We're going to estimate the observational data in the population with low mortality. This is our population we would like to know about. But for our simulation model, in some cases, some of our data will come from the high mortality population. Okay, so what do we get? So here I've simulated data where I know what the true value is, and I know that the true value is that this is an ineffective treatment. And that's just so that it's easy to see the bias. If we simulate a beneficial or a harmful treatment, we still find bias, but it's a little bit harder to read. So if we look at what we would expect to happen if everyone were always treated versus if no one were ever treated, the difference is pretty close to nothing in the G formula. If we increased our sample size for the simulation, this would basically go away. If we make a simulation model where we take all of our parameter inputs and we estimate them directly from the target population, so nothing is based on an assumption, everything is estimated from our single data set, on our target population, you can see that we actually obtain the correct results here. On the other hand, if we take all of our parameter estimates and get them from the other populations, so we take, say, our only data is on the high-risk population, we estimate all of our parameter values there, and we plug them into our model, what we see is that because in both populations treatment is ineffective, and because we've taken all the parameters still from a single population, we actually get the correct effect estimate. So it's basically a null effect, but our individual risks under the different treatment strategies are completely wrong. Both these types of simulation models are possible to do, but the much more common one is to mix and match parameters. So here's what happens if we take some parameters from one population and other parameters from another population. And you can see here that now we're getting the risk under, if everyone were treated, is now the wrong risk. It doesn't reflect either population, and our risk difference or our causal effect is wrong as well. So this is now a 1 percentage point difference instead of a 0 percentage point difference. So can we estimate causal effects from agent-based models or other simulation models in theory? The answer is yes, if our assumptions are all correct. Which is a big if. So the next question is, can we do this in practice? So I'm going to show you an example that uses data from the HIV causal collaboration, which is a data set of individuals with HIV in North America and Europe. And I'm going to compare it to a really large, well-parameterized model of AIDS progression called the Cost Effectiveness for Preventing AIDS Complications, or CPAC model. And then we're going to use sort of similar analysis strategies that we just talked about. So if we look at our data set in HIV causal, and we look at individuals who first presented for HIV care between 1993 and 1997, our observational data analysis with the G formula shows us that people who are immediately treated with antiretroviral therapy had about an 8 percentage point mortality over 7 years. And if they waited until their CD4 count was less than 350, that went up to about a 9 percentage point mortality. If we ran the CPAC model, we actually see basically exactly the same results. So this is really great news. When we run the simulation model, trying to answer the same question for the same time period, we get good agreement in the absolute risk estimate and a good relative comparison of the initiation strategies. So can we estimate real causal effects for real data? Yes, again, when our assumptions are correct. But what happens if we violate some of the assumptions? So we chose 1993 to 1997 because this is when the original CPAC model was first developed. And a lot of the data that goes into coming up with the parameter values was estimated from that time point. But what happens if we use the model and try to make inference about individuals who present to care in 2003 onwards? So this is 2003 to about 2010 at this point. Now we expect that maybe some of the inputs might no longer be appropriate, and possibly some of the model structure may no longer be appropriate. So as a refresher, here's what we saw in 1993 to 1997. And in 2003 onwards, you can see in the HIV causal data set, actually mortality has dropped by about half. And an interesting thing about this cohort is that people tended to present to care a lot later in 2003 onwards. So the benefit of starting early has gone away for this cohort just because most people actually don't start early. Now, what about when we look at the CPAC model? So the simulation model, we see a little bit of a decrease in mortality to maybe around 7 percentage points for the immediate and partially delayed initiation strategies. But we still see this uptick where if you really delay initiation, you have much worse outcomes. So now we have a problem. We have poor agreement in both the absolute risk estimates and the relative comparisons of initiation strategies. So as I said, we suspect that some of the parameters may no longer be correct. And so one possibility to explain why we see differences is that some of the direct effects may no longer be appropriate. And one of the reasons to suspect these is that direct effects here are really not something that we can calculate. I'm going to talk about this more in a second. But in the original model, these were assumptions based on expert best guess. So we have the direct effect of treatment on opportunistic infections, not mediated via cell count, CD4 cell count, which is the red arrow, and then the direct effect of treatment on chronic AIDS-related death, not mediated via CD4 cell count, which is the blue arrow. But we can't calculate these effects directly, as I said, because direct effects require that we know and measure all mediator outcome confounders. And we actually know for sure that we don't have several important CD4 count outcome confounders in our HIV causal data set, because that's not necessarily the focus of that data set that was collected. And then the second piece is that we need direct effects to have well-defined interventions on the mediator. And now the problem is, what does it mean for treatment to prevent death holding CD4 constant among somebody with HIV? We have no way to hold CD4 count constant if we give someone treatment versus if we don't give them treatment. And so we have no way to understand what that effect would mean and how to answer that question. So a solution, instead of actually getting better estimates directly for those parameters, we can calibrate the model. And calibration of models is a pretty standard tool for simulation models. But when we're using them for causal inference, we want to remember that our goal is to calibrate the model to a causal target so that we know that we are able to actually get the causal inference that we want from our model. It's not that helpful to calibrate just to some observation in the world, because that won't necessarily tell us if our causal effect is valid. So we're going to use those range of treatment strategy estimates that we previously obtained with the G formula, and we're going to use them as targets for calibrating the CPAC model. And the benefit here is that because we're saying this is what happens under a universal treatment strategy or a less than 350 treatment strategy, we don't have to know what the treatment distribution is in the target population in order to calibrate our model. So this slide has a lot of data on it, and I'm not going to go hugely into it, but just to say, you can see on the top, there are grids of various different values we tried to vary the parameters for. And the black boxes indicate where the G-formula point estimate overlapped with these grids, with the lighter gray boxes indicating the confidence interval of the G-formula. In the bottom, you'll see the survival curves, where the darkest line is the G-formula or observational estimate, and the gray line are different simulation estimates. So the key thing I want to point out here is that we get a black box on initial universal initiation, a black box on initiation at a sort of moderate CD4 count, but no black boxes on the CD4 count less than 350. And if you look down at the graph, you can see that's because all of the CPAC simulation model runs over-predict mortality, no matter what we set these parameters to relative to the G-formula in that case. So we played around with tweaking this, and we picked some values for a calibrated model. So I just want to show you how much that improved the situation. So as a reminder, this is our G-formula estimate and our uncalibrated estimate. You've seen these numbers before. When we calibrate the model with varying those two parameters, we now get basically almost exactly the same value for the intermediate scenario, but we see this, again, poor agreement in the relative comparison of strategies. So at least one of the absolute strategies is better. They're all coming down much closer to where we expect them to be, but we're seeing a difference in the relative comparison of strategies. So this was sort of the first step calibration. The next thing we suspect is that there may be some differences in the model structure, which describe how the progress of the disease when someone is not on treatment, because people who are starting treatment less than 3D4 CD4 count spend more time not on treatment. Okay, so I just want to kind of wrap up with what we've seen here. So if we have a theoretical example where we think that where we know the truth, we're able to replicate the truth when our model assumptions are right, and we fail to replicate the truth when we know our model assumptions are wrong. When we have real data, we are able to sometimes replicate the truth, and sometimes we fail to replicate the truth. Well, sorry, truth isn't quite the right word. We're able to replicate another study using a different method, which is in this case the observational study, and sometimes we're not able to replicate it. We suspect it, at least in this example, that the times when we didn't replicate, that it was the model that was wrong and not the observational data that was wrong. But it's possible that both of them could be wrong, or they could just be asking slightly different questions. So this is sort of a case where you need to kind of pull apart what you're doing a little bit more carefully. And then the last thing we want to remember is that this was for the absolute simplest case of individual level simulation models. So we assumed that we knew the important things for an individual's life history, but we weren't trying to figure out transmission of information. We weren't trying to figure out the environment. We weren't trying to figure out neighborhood effects or anything like that. When we add in pieces like disease transmission, it gets much harder to get something we can think of as the right answer. And part of this is because we can't even easily estimate a causal effect calibration target. In some settings, we have tools for causal effects under settings of disease transmission. Particularly, we have methods for randomized trials for things like vaccines. So this might be a cluster randomized trial or something like that. And so one thing to do is try to emulate those types of trials when we're using our simulation model for disease transmission. But sometimes that's still not quite answering the right question. So we need to think much more carefully when we're looking at settings where we're interested in disease transmission. Okay, so I just want to wrap up there so we have some time for questions. But the main take home here, when our assumptions are good, we can use simulation models for causal inference. When our assumptions are wrong, we can get the wrong answer, but we don't actually know when our assumptions are wrong, and we don't actually know what the right answer is. So now I'm happy to take questions, and then we'll wrap up. Okay, so there's a question here in the chat box from Morgan that asks any Bayesian or simulation way to estimate the true number of cases with some uncertainty, because reported number of cases tend to be underestimated. Yeah, so that's a great question. So if we wanted to use an approach like this to estimate what the true number of people with COVID, for example, is, and all we have is the number of people who are tested, what we would want to think about are, what are the reasons people get tested? What are the ways in which the test can give a bad answer or good answer? And we want to build those into a structure of our model. So we might, probably an individual level model would be the easiest for that, but we could potentially use a group level model, and we would have some set of variables which determine if an individual gets tested, some set of variables which determine if they get tested, do they actually get a correct result or an incorrect result, and then we could try to back calibrate that based on the observed number of positives in the population to figure out what the initial number of true positives in the population should be. And I think that there are some people working on that for COVID. There's a second question here from Alvaro. How many parameters do we use for the CPAC model? So the CPAC model is a huge, huge, huge model. There are at least 500 parameters. So for this, a lot of those parameters kind of govern the basics of how the virology of HIV works. And so many of those parameters are ones that were initially obtained in the early, mid to late 90s when the model was first set. And then there's other parameters that are being updated over time. And so that's part of why we saw that it did a great job compared to the 1993, 1997 data set, but not quite as good of a job compared to the more recent data set. So this is kind of a good reminder that even a really good, well-designed model needs to be continuously updated over time to make sure that it's staying relevant to the data. So there's a question here from Harvey. What are some examples of models that can be used for non-communicable diseases? So exactly these types of models that I talked about can also be used for non-communicable diseases. In the example of the CPAC model, that's actually almost a non-communicable disease in that we're modeling the progression of HIV in an individual. But there are lots of examples of people using these models for all kinds of things: cardiovascular disease. The Congressional Budget Office's model of health insurance is, I believe, an individual level simulation model. And they're really common in health policy, both the group level models, which they call them Markov cohorts a lot of the time, or the individual level models, which are often in health policy called microsimulations. So they can be used for really any kind of disease or decision that you want to take. Yaroslav asks, what are the good textbooks for self-study of modern approaches to modeling an epi? And I think this is kind of a big open question. There actually are not a lot of infectious disease modeling textbooks. I have a couple which I can maybe look up the names of and have Nick add to the page after this, but there's not one that really links this idea of thinking about the causal effects with modeling, so you kind of have to go to a causal inference textbook and a modeling textbook to get the full picture. Rita asks, what are the best tools to generate agent-based models? So if you want to have an agent-based model where you've got transmission or environment effect layers or other types of contact layers, you're probably going to want to eventually use something like C++. There are some tools like NetLogo, which can be useful for small models or for sort of starting to figure out how your models work. But you can also make simulation models in really any software language. In the non-transmission case, the models are much quicker to run. And so I actually made this model in SAS. You can make models in R, and they'll run relatively quickly. And then there's another question here. When working in novel or uncharted areas where there's limited or no data at all, what are good sanity checks to increase confidence? So one of the things to remember about simulation models is what we said back in the beginning, which is that they're really a way of taking everything you think you know about a topic and synthesizing it into a quantitative estimate. So when you do that, you shouldn't be really surprised by the answer. If you sort of pull together your best knowledge on a disease or an outcome or whatever, and then you run it through the model and it tells you something you're like, wow, I would have never expected that in a million years, probably your model is wrong. Because it's very unlikely that the common thread of all your knowledge together would produce something that's super far outside your current state of knowledge. What you should sort of, so a good sanity check is that you run your model and you're like, yeah, okay, good. That fits with about what I expected. So that's sort of when you really have no actual data or very limited data to work from, that's a good thing. One of the flip sides of that is that you shouldn't get to a point where the actual numeric answer was easily obvious from the inputs without even running the model. So if for example, I assume that 50%, there's 50% underreporting of COVID in terms of testing. And then my model comes out and I'm trying to estimate the total number of people who are infected, and that number is just twice what I originally had. Well, that's not really a model result. That's just 50% flipped over and multiplied by the number of people that I originally had. I didn't need to use a model to do that. So that's the other side. If your model is just providing something that you didn't even need to use the model to get the quantitative answer for, then that's also probably an indication that you're using the wrong type of model or you're modeling the wrong question. There's a shout out to our Casual Inference podcast here from Yaroslav. Yes, so I have a podcast called Casual Inference, co-hosted with Lucy D'Agostino McGowan. And yeah, it would be a really great idea to do some content there on modeling approaches. And I think we will try to do that sometime in the future. Thank you for that suggestion. Juliana says, in Mexico, the government is using a Sentinel surveillance model to get an idea of how many cases of COVID we have because we don't have many tests available. So a Sentinel surveillance idea is usually based on sort of choosing some particular places where you're going to test just in those areas to kind of get a sense of what's going on with the disease. Sometimes that may not even use actual testing. So in the US, we have sentinel surveillance for influenza-like illness every year, and that gives us a sense of how much the flu is happening, when the season is starting, how big the season is going to get, etc. So I think that's a reasonable approach. If you really can't get tests, you need some way of kind of checking what's going on. There are actually lots of different kinds of ways to do sentinel surveillance. Some of them are sort of spot testing. Some of them are looking at related things. I've heard of examples in the past of using pharmacy data. So, over-the-counter sales of Tylenol, for example, as a sort of sentinel marker of some kind of disease spread in a community. And obviously, those things are not as good as having the tests and actually getting the numbers, but they can potentially give you some signal. The problem is that if you're looking at something like, sales of Tylenol or Google keyword searches for COVID, there's going to be a certain amount of dilution from the worried well or people who think that they may in the future get this condition or are just interested in it. That's going to dilute your signal a bit. For Margaret, is asking about a go-to text or reference for understanding the G formula. So what I would recommend for anyone who's interested in that is to look at the Causal Inference What If book by Miguel Hernan and Jamie Robbins. That book is actually freely available on their website. They're both faculty at Harvard School of Public Health. So if you Google Causal Inference book, Miguel Hernan, you will find that freely available as a PDF to download. And that really is designed as an introduction to all things causal inference, regardless of whether or not you have any particular background in epidemiology or statistics or anything. It's for a sort of general audience. And then Mike asked what metrics are used to choose parameters. So when you're picking parameters, you want to try to sort of, ideally, since we don't actually know the parameter ranges, ideally you want to pick the values which seem the most likely to be relevant for your target population. So this is where we want to think about, were a study that estimated a parameter, did it control properly for confounding? Did it control, did it not have any open colliders? Did it adjust for all of the possible common effects of treatment and the outcome that might be relevant for the variations between that population and my population? And those are the kinds of things you need to think about sort of qualitatively to decide if the parameters are right. When you don't know, or don't have a lot of confidence in the parameters, instead of sort of picking a parameter based on some metrics, you really want to try to pick a parameter distribution and then see how sensitive are your outputs to that variations in that particular parameter. And if the outputs are really sensitive, then you know that your results are not really that, you can't really be that confident in them. From Corey says, is there a guideline for the number of parameters? So really this is up to, depends on what you're estimating. My advice generally is that, you want to start by thinking about what are the sort of key, regardless of whether you're doing an individual level or group level model, you want to start by thinking what are the key types, groups or categories of people that you're interested in. And then start kind of thinking down to this more subgroups and the variables that are important. Then I think the ideal thing would be to draw a causal graph or like a directed acyclic graph and use that to kind of figure out what are all of the parameters that you could potentially have. The maximum number of parameters is basically the maximum number of arrows that you have on your causal DAG. A lot of the time we actually, that's not quite true, because sometimes you'll have, as I said, like with CD4 count, if that mediator has multiple values, then you may need multiple values for the arrow that goes directly from treatment to the outcome, holding that constant. But that will sort of give you an estimate of the types of parameters you need. And then you can think about making some assumptions that, for example, you may say, well, this actually doesn't vary by age, and so I can kind of collapse this parameter over age. So computational complexity and how long the models take, which is a question from Charlie. This is, I think, the biggest limitation on most models. So, I have some models that I can run on a desktop computer in a half an hour, and I have other models that run on a server in a week. And you really need to think of the trade-off between how much computation is this model going to take, and how much do you actually need to include in your model to think about a good estimate of the outcome. So you're going to want to include, all of the confounders, but maybe you don't need to include all of the mediators. So that's something to think about. In terms of the population size, which is the other part of Charlie's question here, generally you want to run a relatively large but not overly huge population size. So one of the sort of types of uncertainty people recognize in simulation models is stochastic uncertainty. So since we're using random numbers to draw our values, there is some random error that comes into our models. Basically, you want to either increase your models or increase sample size or increase your number of runs until that amount of error stabilizes. So, 10 or 100 people is too few, 1,000 might be okay, 10,000 might be better, 100,000 might not make much more difference. And it's really going to depend on your model. Okay, so Morgan is asking a question about whether or not we should assume that events are independent. So in the things that I was showing you, we were kind of making that assumption that each individual, things were happening to them in a way that was independent of other individuals. Whereas in something like COVID, when we want to start modeling that, now we have potentially dependent exposures, dependent events. Example here of, if you're trying to model bed space, some of the beds might be taken up. So there are different ways of kind of dealing with that. So One option is to, use extra layers in your model, and then you want to kind of think about simulating that model in a way that kind of answers, basically the challenging thing is to ask the right question. So you want to ask a question that you can understand the answer to. If you're just worried about the events sort of overlapping, or for example, you're trying to model hospital bed usage and at some point they're full, you are not going to need to change your model too much. You're just going to need to have a layer that represents the hospital beds and indicates when a hospital bed is taken up. But there also, I actually have a paper on arXiv that kind of looks at resource usage limits and how to incorporate that into the observational data case. And some of that could also be done in a simulation model case. So I think we're all out of time now. I see in the chat box that there are a lot more questions. I would definitely encourage you to tweet those at me. My Twitter handle is @EpiEllie. And if there are some questions that are already here, I'm happy to get those by email and respond to them. So thank you very much to everyone joining. Hope you learned something.